Hello, good evening, all our friends and members of Maharashtra Ophthalmological Society, and those of us who are joining us from at large from all the memberships from the All India Ophthalmological Society, especially all our young stars, our postgraduates, and young ophthalmologists. So, on behalf of Maharashtra Ophthalmological Society, we all welcome you. I am Dr. Vardhaman Kankaria, Chairperson of the Scientific Committee of MOS, and we have been very happy to concentrate on postgraduate programs this year. And this year, the theme has been that each month we have dedicated one specialty to 1 month. And this month's specialty is very interesting, probably one of the most academic specialties that we have in ophthalmology, which is uvea. Friends, we all know that during post graduations, we do not get enough exposure of uvea in majority of our medical colleges. So we are very lucky to actually learn from today's mentors and our national and state panelists. So we would like to welcome Dr. Partho Pratim Datta Mujumdar, who is a very, very dear friend of mine and who is the consultant of the UVA in UVA department at Shankara Nethralaya and also the chairperson of scientific committee of SN Alumni. We also welcome Dr. Samyak, who is a MOS faculty and who is currently the consultant at Hinduja. Today's session will be mentored by Dr. Varshav Gore and Dr. Hiteshi Jain. So we would like to welcome you as well. And of course, we are very thankful to our very dynamic postgraduate course coordinator who is doing very sincere hard work throughout the year. And that is, of course, Dr. Sumit Lahane. Dr. Sumit has been instrumental in coordinating all these programs month by month very, very meticulously. And today's session will be, of course, moderated by Dr. Ashish Jain. And we are looking forward to our young presenters, Anuja and Venya. So before we go further, I would like to now request our Honorable President, our guiding force, Dr. Santosh Agarwal, sir, to give his welcome address. Over to you, sir.
Thank you, Dr. Vardhaman. Respected seniors, dear colleagues, and my postgraduate friends, very good evening to one and all. I welcome to you all to this webinar. At the outset, I express my heartfelt condolences to Sumit and Lahani sir on the sad demise of his grandmother. And I also thankful to Dr. Sumit, Vardhaman, Aditi for organizing these webinars regularly. I am very much grateful to Dr. Partho and all panelists who have taken time for this webinar. I appeal all PGs to please do attend these webinars, which will definitely enlighten you all and also help to face the practical exam in postgraduate course. Please listen carefully to each word of our panelist so you will understand the subject, because UVI itself is a very complex subject and you have to go through the very minute details of this entity. So please concentrate or focus on whatever they are saying, and also don't hesitate to ask the questions to our mentors and experts. And all the best to today's PGs who are going to present the cases. Today's my quote is very famous quote already written on my backdrop: arise, awake, and stop till the goal is reached. So your goal is in front of you and you have to chase that. So all the best. Thank you very much. You are muted, I think. Vardhaman, you are muted.
Yes. Sorry. Thank you very much, sir. And as you have correctly said, we definitely respect uh, that Dr. Sumit, in spite of the unfortunate event in his family, has joined us today. And that shows his sincerity towards his work and his work ethic. So, on behalf of MOS, Sumit, please accept our heartfelt condolences. And we are all with you in this, definitely. So, what do you, Sumit, for further course? Thank you so much.
Thank you, sir. And thank you, Team MOS, for being a very supportive family and for having this platform for all the postgraduates. postgraduates I speak to a lot around all over the Maharashtra, and they are finding this very useful, and they keep coming with a lot of queries and the new suggestions. And MOS office is very happy to help them, and we are very thankful for the MOS for providing this platform to them. So for today, we have Dr. Patham Majumdar. He does not need any introduction, but as a formality, he is a senior professor at SN Chennai UVI department. Sir is very well known for his e-learning website eOfta, which was first of its kind, providing ophthalmic study resources much prior, like since 2007. Sir has more than 200 publications, 12,000 citations, and he's like an encyclopedia of uveitis and ophthalmology, a great photographer, teacher, and an ever smiling face dealing with the most complex cases. Thank you, sir, for being here and taking out time. We have our MOS faculty, Dr. Samayak Mulkutkar sir. Sir is a senior consultant at Hinduja Hospital. He is alumni of PGI Chandigarh and has a keen interest again in a complex uvea cases. And he is a go-to point for all ophthalmologists in Mumbai for such difficult cases of referral in uvea. Thank you, Samayak sir, for being there just on a single message. Our mentors for today is Dr. Varsha Gore sir. Sir is a professor and the head of the department at MGM Medical College, Navi Mumbai. He is one of the most approachable head of the department I've ever come across, and his attitude towards PG teaching is marvelous. He goes a miles apart to make sure that his PGs get a best exposure, and that is very rare to see nowadays. Thank you, Varshav sir, for mentoring the students and being here. Dr.
Thank
Hiteshi
you.
Jain,
Thank you, sir.
again a dynamic assistant professor at KM Hospital. Dr. Hiteshi, I know her from her postgraduate days, and she's always been very dynamic and a research-oriented postgraduate student. Now mentoring her own students, and this is very nice to see, Dr. Hiteshi. Thank you for being here and mentoring your student. My dear friend, colleague Dr. Ashish Jain, who has done his fellowship from Nagpal Institute and JJ Hospital. He is a retina surgeon, a very excellent one, and working presently at Mumbai. And the actual celebrities for today, Dr. Venya Sharma and Dr. Anuja, who are postgraduate students from MGM and KM Medical College, will be presenting their cases. I would like to wish them best wishes, and of course to tell them that presenting a UVA case in front of such faculty itself is a task, and you agreed to do it, and you are doing it is itself is accomplishment. So very congratulations and best wishes for you. I will hand it over to Dr. Ashish, and Dr. Venya will be starting a presentation. Ashish, over to you. You can unmute.
Yes, sir. So, welcome everybody. Thank you so much, sir. Thank you, MOS, and all the panelists for having me here. So, today the first case will be presented by Dr. Venya. She's a postgraduate from KEM Hospital, Mumbai. She'll be presenting a case. And Venya, can you share your screen now?
Yes, sir.
So we'll go through the PowerPoint first, and then the panelists can give their expert opinions, and then they can discuss on the case further. So over to you, Venya.
Is my screen visible?
Yes, it is.
Good evening, everyone. I will be presenting my case on Eales disease. So, a 23-year-old male resident of Navi Mumbai presented in the ophthalmology OPD with the chief complaints of seeing black multiple floaters from the right eye since a week. It was sudden in onset, painless in nature, and progressive, and it moved with the changes in his head postures. He had no history of ocular trauma, no history of spectacle usage, no history of ocular surgery, no history of cough, fever, or weight loss, no joint pain or joint swelling, no skin rashes or mouth ulcers, no history of any medication consumption, and no history of systemic illness like hypertension or diabetes mellitus. He, in his past medical history, he had no history of TB or TB contact, no history of alcohol consumption or tobacco consumption, and he does not have any history of drug allergies. His family history was not significant. Patient was conscious, cooperative, and well oriented to time, place, and person. His vitals were stable. Upon ocular examination, his head posture was normal, facial symmetry was present, ocular position was normal, and extraocular movements were free, full, and painless in all gazes for both eyes. The visual acuity of right eye unaided was 6 parts, and it was not improving with pinhole. Color vision and Amsler grid were within normal limits, and his vision of left eye unaided was 6, and color vision and Amsler were normal. On slit lamp examination of anterior segment, his of the right eye, it was within normal limits. His anterior chamber was von Herrick grading 4 with no cells. It was quiet. Pupil were reacting 3 round reactive and regular, and lens was clear. And of the left eye, again, the anterior chamber was quiet. Pupil were 3 round reactive regular. There was no RAPD, and the lens was clear. His IOP with Goldman application tonometry at 11 a.m. in the morning was of both eyes were 12 of mercury, as well as adjusted IOP was the same for both eyes. Upon his dilated fundus examination of right eye, so vitreous hemorrhage was visualized in the inferior nasal quadrant. His optic disc had a healthy neuroretinal rim. It was normal in shape and size. CD ratio was 0.3:1. There was mild tortuosity of the vessel. There was vascular sheathing that was present. His macula was normal with a foveal reflex, which was present. And in the periphery, there was neovascularization, which was visualized along with vascular sheathing. The fundus examination of left eye was normal. This is a picture of the right eye, where in the inferior nasal quadrant, vitreous hemorrhage is visible. There's neovascularization on the nasal side, as well as vascular sheathing in the inferior half. This is the fundus photo of the left eye, which was normal. So based on the clinical and the history and the clinical examination, the differential diagnosis came to two types, either ocular inflammatory conditions or systemic inflammatory conditions. Under ocular inflammatory conditions, it was either Eales disease, idiopathic retinal vasculitis, or frosted branch meningitis. In systemic inflammatory conditions, it could be tuberculosis, sarcoidosis, Behçet's disease, syphilis, or systemic lupus erythematosus. His ocular investigations were done. OCT did not show any macular edema. Systemic investigations were normal. The complete blood count was within normal limits. C-reactive protein and ESR were mildly raised. Montour test was around 9 in duration. IGRA was positive. However, respiratory medicine reference was given. They ruled out systemic tuberculosis and sarcoidosis. Serum ACE level were normal. Serum homocysteine was normal. Serum anti-nuclear antibody was negative, triple H was negative, RPR was negative. His random blood sugar was 84 and HbA1c was 5.4. So based on the investigations, it was diagnosed to be a Eales disease, which was managed through oral corticosteroids, and the patient was observed for a vitreous hemorrhage resolution, after which laser photocoagulation was done. Patient is on regular follow-up for visual acuity and dilated fundus examination monitoring of the affected eye as well as the other eye.
Okay. Great case, Venya. I would like to ask Dr. Hiteshi ma'am if you have any questions for Venya ma'am. Hiteshi ma'am?
Yeah. Good evening, everyone. Hi, Dr. Venya. That was a very nice presentation. So there are a few questions that we would all like to ask you. Can you enumerate a few common causes of vitreous hemorrhage in young patients?
Yes, ma'am. So in young patients, the first and foremost would be any kind of ocular trauma, may it be blunt trauma or penetrating trauma. Another can be any proliferative vascular condition such as Eales itself or central renal retinal vein occlusion or branch retinal vein occlusion. Or it could be any inflammatory condition such as sarcoidosis or ocular TB where neovascularization is occurring and then the rupture of those vessels can cause vitreous hemorrhage. It can also be associated with subarachnoid hemorrhage, like in Turson syndrome, like in hemorrhage. Or it can be associated with any choroidal condition such as choroidal melanoma, or with any blood disorder such as hemophilia or thrombocytopenia.
Okay. Uh, what ophthalmological and systemic investigations would you like to perform in a patient of recurrent vitreous hemorrhage?
Ma'am, for like ocular investigations, firstly, we should see a proper dilated fundus examination in order to rule in or rule out any kind of neovascularization which is causing the vitreous hemorrhage. Or we can also do if the media is completely hazy and vitreous hemorrhage is completely obscuring the view, then we can do a USGB scan to assess any associated retinal detachment or retinal tear that may have occurred. Or we can also do an FFA to see again to rule in or to rule out neovascularization that may be present. And in systemic, we should keep in mind the conditions that I had just listed, like tuberculosis or maybe sickle cell retinopathy. So the investigation should corroborate to that diagnosis.
Okay. Any studies that you can talk about related to Eales disease?
Yes, ma'am. So one of the significant studies that was done, it was in India 2002, where there was an association. It was done to create an association between Mycobacterium tuberculosis strain and Eales disease, where around 69 patients, where 24 patients were of Eales disease and the rest were of non-Eales disease. A control group was taken, and the vitreous fluid of each of the patients were taken and then tested through PCR for Mycobacterium tuberculosis, where a significant amount was a significant relation was established, where 5 patients from Eales did come positive for Mycobacterium tuberculosis. So here it was emphasized that there is an association of Mycobacterium tuberculosis as a etiopathogenesis for Eales disease. And another study was done, ma'am. It was by Saxena and Kumar in 2004, where it was basically for staging of to create a simple staging for Eales disease. So there, 253 patients of Eales disease were taken in.
All right. Okay. And lastly, can you tell us about the stages of Eales disease?
Ma'am, there are basically 4 stages. One first would be the inflammatory stage where the vasculitis occurs, and then it where sheathing and cuffing is visible. Then it goes down to the stage of ischemia or occlusion, where superficial retinal hemorrhages may be visible, which then leads to the stage of neovascularization when there's capillary non-perfusion areas which are seen. Then then neovascularization occurs at the junction of perfused and non-perfused retina. And then there is stage of sequelae where vitreous hemorrhage would occur. There can be persistent vitreous hemorrhage can cause tractional retinal detachment. It can also cause neovascularization of iris and secondary glaucoma.
Right. Back to you, sir.
So very well done, Venya. Thank you, ma'am, for your questions. So I would like to ask the panelists on what are our current understanding about the East disease, mainly seen in the Asian subcontinent, not seen much in the West. There's very little studies that we've seen. So what is our current understanding of the disease? Ma'am, can you please?
I think it is for either Parthos or Dr.
Okay. Okay, okay. Yes. So, Partho sir, Samyak sir.
Samak, you
Yes,
want to?
so yes, sir. You want to go ahead?
Yeah. So my understanding for the postgraduate, I will divide it into two parts. The first part is the what a postgraduate should know for the exam. So for the postgraduate, the Eales disease is basically a idiopathic periphlebitis, which is often bilateral. And you have to understand that this is a disease or disease of exclusion. That means you see a patient, young, particularly young individual with retinal vasculitis, and you have to rule out all other causes of retinal vasculitis, And after you have ruled out and there was no etiology, then you can label it as a Eales disease. So if you go back by the history, Henry Eales, when he diagnosed it, he suspected that it can be related to constipation and epistaxis. And then there are several etiology or hypothesis was put forward, somebody related to syphilis and all. And of late, the second part of my is that the tuberculosis. Now, two things are common with tubercular retinal vasculitis and Eales disease. Number one, the capillary perfusion. These are always, the Eales disease is always occlusive in nature, and so is the tubercular retinal vasculitis also. And in a country like India, if you see, there are a lot of paper which has emerged out that there are possible role of mycobacterium which has been associated with this kind of group. Now, for example, if you see that there was a case report where the epiretinal membrane was isolated, and when tested for PCR, it showed that the presence of mycobacterial genome. So, likewise, there are several studies which has isolated the mycobacterium from the samples of the Eales disease patient. But till date, we are seeing some cases where there is no correlation with that. So you can say that the spectrum of Eales disease has narrowed down with the advancement of the molecular diagnostics towards the many of these cases has been labeled as a mycobacterium tuberculosis or tuberculous retinal vasculitis, but still that spectrum exists. So for postgraduate, you have to remember it's a idiopathic retinal periphlebitis, which is most commonly bilateral, and it involves the young patient.
Yes, so I think we've had a very good answer by Partho sir, who's obviously the expert here. So, what investigations do we need before we term it as EZs, or what investigation would you all like to do when you see a case of occlusive periphlebitis in a young male individual?
Correct.
Samek sir?
Because I think our Dr. Vania, right? So she has touched all points. One thing I must highlight here, that when you are taking history of retinal vasculitis, no, one history you should take the drug-induced uveitis. So there are 5 drugs you should remember which can cause the retinal vasculitis. One is that amphetamine, the methamphetamine. One is dimethoprim sulfomethoxazole, and intracameral vancomycin, which can cause hemicentral CRVO-like picture, and intravitreal brolucizumab. This is a very important cause, so you have to remember that. And fifth is the checkpoint inhibitor. So this drug history is often important here. Now, when you see a case of vasculitis, I'll always tell that you have to go by the clinical phenotype recognition. For example, if a vasculitis is exudative in nature, profusely leaking, it is non-ischemic, then you can rule out that it is not a case of Eales disease. Then, because the sarcoid, one example is classically the sarcoid. Sarcoid is classically, it is almost always exudative, never ischemic. Now, once you have realized that it is ischemic retinal vasculitis, you have to explore the other causes of it. One of them being that Mycobacterium tuberculosis. In a country like India, you should always do preliminary test as you have done. And I can see one question in the box that I would suggest all cases to go for vitrectomy or PCR imaging. And the role of aqueous paracentesis and PCR is limited because most of the cases, this kind of retinal vasculitis, they have limited anterior segment finding. So the vitreous biopsy can be done, but I won't suggest for all cases of Eales disease. It should be highly specific and varies from case to cases. Samak, you want to add anything?
Fluorescent. What again? Where I is patient will have the other eye is second time that they come up with present. So in the FFA,
Audio, I think you are not properly, we cannot hear you,
Is
Dr.
it
Samir.
okay now?
Samay sir, there is still some disturbance happening. I thought only I am getting. Can you try again, sir?
Now?
Everybody is getting that same.
Yeah.
Is it better?
It
Yes, sir,
is
much better.
Yeah.
better.
So I want
So it's again cracking, sir.
it's cracking.
We're not
Okay,
able to.
I
Yes,
am
sir.
switching off video. Is it better now?
Yes, sir. Yes, sir. Now we can hear you.
Yes. So when you look at the fluorescein angiography, you're looking at the other eye as well, not only the eye which is symptomatic and showing you obvious signs. The other eye will also show you some subclinical signs in case, because a lot of these cases will be bilaterally presenting. The other thing what you can do is to, when you look in the angiogram, you should see the areas of non-perfusion. And the areas of non-perfusion, then you can do a targeted laser photocoagulation that will help. Again, in fluorescein angiography, you need to see whether the vasculitis or periphlebitis that you see is active or inactive. If it is active, then it requires oral steroids. And if your TB tests turn positive, then you require AKT. Not every patient will require, but if your TB screening or if your TB test that you do will require AKT. But if you see that it's just the retinal hemorrhage and it's a burnt out vasculitis, then you may not require to give oral steroids. It probably just a vitrectomy or laser photocoagulation will settle those down. Those points I wanted to add.
Okay. Thank you, Samyak sir. I think, sir, we'll come back to the topic on the treatment part. So before that, what are the systemic tests that we would like to do when we are looking at a presumed Eales disease? Because the treatment, the investigation, like what we do with the Mantoux, the TB Gold, HRCT, and a vitreous biopsy, as Partho sir was mentioning. So what would be the sequence, and do we order all, or do we do any other tests, sir?
To your question, Ashish, like Dr. Partho insisted that it would be a clinical evaluation first. So, looking at the clinical picture, you start doing the auditory investigations. For example, if a patient is here in our demography, like in India and around, and a young patient who's between 20 and 40 years of age, a male patient, and has such kind of a picture, then think of each disease. The for example, ophthalmic exam, fluorescein angiography, OCT, and that detailed fundus imaging. Then you go on to systemic evaluation. You can ask a history like Vinay, I think, has asked a detailed history whether there is the contact of tuberculosis or not, and any systemic contact or any other systemic disease which can point towards such a finding in the eye. And I think Dr. Partho also said that this kind of vasculitis also can happen in sarcoidosis. So you have to rule out those things. Laboratory investigations, see ESR, urine analysis, and HIV should be done in most of these cases. You should specifically tuberculin sensitivity test or the MON2 test. Uh, Chest imaging, nowadays it is preferred that you do a high resolution chest CT, which has a better pickup rate of any underlying or old healed tuberculosis or any other features like lymphadenopathy more than the simple chest radiography. TB Gold test is done in cases which are doubtful. You usually don't go as a first line test. We use it very, very selectively. And since syphilis can mimic a lot of things, so you also have to rule out syphilis. So a TPHA, because it's a great masquerader, what they say, you should also do a TPHA. And like Dr. Partho said, that AC tap and vitreous tap are only in selected cases when you are actually going in for a vitrectomy and you are not able to figure out what's the cause. Then only then you have to. I think Dr. Partho can add on something to it.
Oh, I think you have summed very nicely. And I really like that most you highlighted that the other eye FFA you have to look carefully. That is the most important in managing a case of Eales disease.
Great. Thank you, sir. So now moving on to the management part. So with the advent of anti-VEGF in the active stage, then in the inflammatory, ischemic, inflammatory, and then in the quiet stage. So what would be the role of management at presentation, later, and then with the PRP? When would you like to do PRP? When would you like to do anti-VEGF? And later, when is the role of vitrectomy, sir, in Eales disease in the current scenario, sir? Maybe Partho, sir, can start.
Yeah, I think the mainstay of this treatment should be the steroid, oral steroid you can start with. And you have to understand whenever you are diagnosing a case of Eales disease, you have to tell the patient about the possible course of the disease. This is very important. You have to tell him that you can develop recurrent inflammation. So you have to come regularly for the checkup. Even if you are normal, every 6 months or 3 months, you have to come for a quick retina examination. This is number one. And number two, you have to prevent the recurrences. So sometimes the Eales disease, when in absence of other infectious etiology, you require immunosuppressives also. So you need to start this patients little early. That will actually improve their quality of life. Otherwise, what happens? These patients come with recurrent vitreous hemorrhages and all. So any capillary dropout areas and all, you have to do a laser and monitor them carefully. And the combination of proper good immunosuppressives in these patients is very important. Samak, you want to add?
But not the least, a lot. Am I audible?
Yeah.
Yes, now say you
Yeah.
are.
Last but not the least, since a lot of these patients will be asymptomatic while the vasculitis is still going on. It occurs classically in the mid periphery. Macular area is usually spared till the last stage where you have actually a vitreous hemorrhage. So even if you start treatment, have to the young adults that look, don't stop treatment, come for a make all those things are taken care of.
So just to add a question here, is it okay to, like you said, the mainstay of the treatment is steroids, but is it okay to start steroids without ruling out underlying COX in such cases, especially in Indian subcontinent?
Uh, I think it's a very important question you asked, Sumit. But you have to understand that even if it is a COX, the role of TV is oral steroid is important because it will prevent the collateral damage causing the by the inflammation. So good thing is that you can start the steroid and start investigation in investigating the patient also. Second one point, because you raised this issue, I must tell that if this is like picture in adolescence. No, we have done a study and we have seen in children and pre-pubertal age group of children. No, it can be very very aggressive, and often they don't respond to oral steroid. Also, it becomes so severe that you have to give them IVMP and start from like sometimes two immunosuppressives. We actually analyzed the cohort, and but we could not come to any conclusion. We presume that most probably because they are pre-pubertal and the effect of growth hormone has some role, because these patients are notorious to develop neovascularization, florid neovascularization, and vitreous hemorrhage is much common in this children. So I think this is an important takeaway from this webinar, that if you encounter this kind of in children, no, is like you have to be little aggressive while treating them.
So one more thing I would like to ask is, since many of the Eales patients do present with a complication like vitreous hemorrhage because they see floaters around, they will not present in the early stages. When do you think of anti-VEGF, sir?
Tamak, you want to highlight?
So and not able to actually
Samek,
you're not
sir, could you just switch off the video so that the audio is clear for everybody, sir? You're not audible.
right.
Thank
So
you, sir.
if you're not able, sorry. So if you're not able to actually see the area of the capillary non-perfusion, if you're not able to see where you want to laser, especially in the quadrant, but you are assured that there is no traction on the retina, and you want to and you don't want to wait for some time, then you can actually give an anti-VEGF one to clear out the hemorrhage. Then you see that area more clearly, and then you laser to that. Second is if you see macular edema, and if again assured that you don't have any retina, will also have a lot of traction in the periphery. So you don't want to give an anti-VEGF and have a tractional retinal detachment converted into a reg.
For postgraduates, I would like to highlight one thing, that you have to understand that this VEGF is releasing because of the inflammation. There is a inflammation going on in the retina, and because of that, it is releasing. So if you are adding only anti-VEGF in a case of inflammation, you are not addressing the root cause. Okay. So second thing, that there is a possible means one of the characteristic feature of the disease is occlusion. Occlusion, we call it occlusive vasculitis. Now this occlusion is happening because of the anti-immune complex deposition in the retinal vessels and leading to the closure of these vessels. So until and unless you are hitting them with the anti-inflammatory agent, so it is not going to actually cause any effect in the cause of that particular disease. So that's why the anti-inflammatory treatment is very important in cases of inflammatory retinal vasculitis. Even if you are adding like supplementary therapies like anti-VEGF or laser and all, you have to understand that anti-inflammatory therapy is most important, and these are all supplementary therapies.
Correct. Thank you both the Samyak sir and Partho sir for the great insights. I think we'll move on to the second case now. So Dr. Anuja, she's a resident at MGM Hospital, Navi Mumbai, and she'll be sharing the case, right? Anuja, can you share your screen, please?
Yes, sir. Good evening, everyone. I'm Dr. Anuja Gawarle from KM Hospital. Is my screen visible, sir?
Yes.
I'm going to start with the case history. My case is a 44-year-old lady who is a housewife and resident of Mumbai. She came to the ophthalmology OPD with chief complaint of insidious onset, gradually progressive diminution of vision in the left eye, associated with eye pain and frontal headache since 1 month. She also gave a history of fever with malaise 2 months back, which lasted for about 2 weeks and resolved with medications. There was no history of redness, watering, or discharge from both the eyes, no history of photophobia, no history of painful eye movements. She's a known case of type 2 diabetes mellitus, controlled under treatment since 7 years. Apart from that, her personal history was normal, but she did give history of hair fall, which was recent onset, noticed since a few months. In past history, the patient denied any history of ocular trauma or any previous ocular surgery. There were no history of similar episodes in the past, and there were no similar complaints in the family. She gave no history of prolonged cough, no history of weight loss, loss of appetite, no history of joint pain or back pain, no history of COX or COX contact in the family, no history of any hearing abnormalities, no history of any whitish coloration of skin or hair, and no history of contact with pet animals. On systemic examination, the vitals of the patient were stable and ENT examination was within normal limits. However, on dermatology opinion, the patient had alopecia with pre-vitiligo revealed on Wood's lamp examination. Proceeding to ocular examination of the patient, the best corrected visual acuity of the patient in the right eye was 6/18, with near being N12, and in the left eye was finger counting 1 meter, not improving further, with accurate projection of rays. On slit lamp examination, in the right eye, the anterior segment was within normal limits. The anterior chamber was quiet with no cells, and the Goldman applanation tonometry taken at 11 a.m. was 12 millimeters of mercury. Similarly, in the left eye, the anterior segment was within normal limits with a quiet anterior chamber and pressure on Goldman applanation being 14 millimeters of mercury. We proceeded to fundus examination of the patient with indirect ophthalmoscopy, which revealed in the right eye the media was clear. However, the disc had mild hyperemia with 0.2 CD ratio and a few yellowish exudative lesions at the macular area with foveal reflex being absent. The blood vessels were normal. Similarly, in the left eye, the media was clear. However, the disc had disc edema, and there were multifocal yellowish exudative areas all over the macula. And again, the blood vessels were normal. Based on this clinical picture, we thought of the provisional diagnosis as both eyes active multifocal choroiditis with multifocal exudative detachments in the left eye more than the right. Based on this, the differentials were both Koyanagi-Harada disease, tuberculosis, sarcoidosis, syphilis, posterior scleritis, sympathetic ophthalmia, and less likely lymphoma, CSR, posterior multifocal placoid pigment epitheliopathy, and uveal effusion syndrome. We proceeded with OCT macula of the patient, which in both eyes revealed in the vitreoretinal interface where we could see cells, signs of inflammation. The foveal contour was lost, and the internal limiting membrane had multiple folds. There were multiple neurosensory detachments and retinal pigment epithelium folds with subretinal hyperreflective material. After doing investigations of the patient, the blood panel was normal, Montus were non-reactive, and the chest X-ray was normal. We also did serum ACE levels, which were normal. The triple H and VDRL of the patient were negative, and ESR was raised. Based on these findings, we diagnosed the patient as a case of incomplete VKH in a known case of type 2 diabetes mellitus. And we managed the patient with initial high dose of injection methylprednisolone 1 gram per day for 3 days while monitoring the patient's blood sugars, and followed by a shift to oral prednisolone 1 to 2 milligram per kg per day with slow tapering. We followed the patient up, and on a serial follow-up at 6 weeks, her vision in the right eye improved to 6/6, whereas in the left eye it improved to 6/12 with the OCT image as shown. There was a marked resolution of the disease. Thank you.
Thank you, Anuja. So I'd like to ask Dr. Gore sir to proceed with a few questions to Anuja sir on the case.
Fine. So Anuja, Dr. Anuja, you presented case quite well. I would like to ask you a few questions. Can you talk about ophthalmic and non-ophthalmic clinical manifestation of VKH syndrome?
Yes, sir. Thank you for the question, sir. So VKH or Vogt-Koyanagi-Harada disease is a chronic granulomatous pan-uveitis, essentially. So with systemic findings. So in the ocular manifestations, the patient, according to the stage of the disease, is going to present. Initially, there might be some prodromal flu-like symptoms like fever and malaise, and followed by in the acute uveitic stage, patient will present to us with bilateral involvement, with a diminution of vision with some pain in the eye, both eyes. And on findings, we will see in the anterior segment, we may see granulomatous keratic precipitates with anterior chamber reaction in the form of cells and flare. We in the fundus examination, sir, we will get to see multifocal choroiditis with serous detachments, and there may or may not be disc edema as well. Then in the non-ocular or extraocular manifestations of the disease, there may be neurological, auditory, or integumentary findings. In neurological findings, one key feature is CSF pleocytosis. However, it's not tested for usually. The CNS symptoms may be non-specific like meningismus to some focal neurological deficits as well, followed by auditory symptoms with which will be tinnitus, vertigo, and even sensory neural hearing loss. After that, integumentary findings we will get in the later stages of the disease, usually in the convalescence or chronic phase, It will be associated with hair fall, alopecia, that is alopecia, then vitiligo and poliosis.
Okay, good. So these are the findings which help you come to diagnosis of weak age. Fine. So tell me the differential diagnosis of weak age syndrome.
Yes, sir. So, such clinical picture could be appreciated in very similar picture would be seen in a case of sympathetic ophthalmia. Uh, Other differentials would be tuberculosis, sarcoidosis, then syphilis can be there. One of the DDs is also a central serous chorioretinopathy. And apart from that, we may get similar pictures in inflammatory conditions such as APM, PPE. And one DD that we get with similar findings is posterior scleritis.
Okay. So the next question is, how will you differentiate between sympathetic ophthalmitis and weak age?
Yes, sir. So the key difference between sympathetic ophthalmitis and leakage is the presence of a history of penetrating ocular injury or a history of previous ocular surgery in the other eye. So in sympathetic ophthalmia, it is essentially a chronic granulomatous disease with a history of insult to one eye followed by a response in the other eye. However, there is no such history in VKH, so it can be ruled out in this patient as well. Apart from that, sir, the age of presentation in sympathetic ophthalmitis from the history of trauma can be at any age. It can be immediately after a few weeks to many years later. However, in VKH, the age of presentation we can limit to at like 20 to 50 years of age group. Race predilection is also seen in VKH, which is most common in Asian and Black population. There is no such thing in sympathetic ophthalmitis. As for the clinical features, many are similar, but we may get a clinical feature of serous retinal detachment in the later stage of VKH, which is not usually there in sympathetic ophthalmitis.
Okay. And tell me about the stages of weak age.
Yes, sir. So, leakage stages can be divided into four stages. The first is the prodromal stage. As I said, in the prodromal stage, there are flu-like symptoms with some neurological, with or without some neurological symptoms. Then followed by that is the acute uveitis stage. It is in which the patient will present with bilateral symptoms of uveitis, pan-uveitis, and anterior and posterior segment findings may be there. Followed by the third stage, that is the convalescent or chronic stage. In the convalescent stage, we are going to get more of depigmentation findings, like depigmentation of the fundus. So that presents as sunset glow appearance on the fundus. Also, a perilimbal vitiligo that is known as Sugiura sign can also be appreciated in this stage. Apart
Yeah.
from that, dermatological findings are also more appreciated during the convalescent phase. If the patient is not treated, the patient is going to have chronic recurrent stage. That is the fourth stage of VKH, in which the patient's uveitis symptoms will recur, and there may be some complications related to VKH, such as cataract, glaucoma, subretinal fibrosis, or a neovascularization of the choroid.
Fine, fine. Thank you.
Thank
Nice.
you, Bole sir. Thank you, Anuja. So I
Thank you,
would
sir.
like to invite Partho sir and Samyak sir to join the discussion now. So, sir, what are our current understanding of the disease, Vogt Koyanagi-Herda syndrome? What do we currently see, and what is the current understanding of the disease? Partho sir?
Yeah, I think from Anuja's and sir's question and answer, a lot of things is clear. I just want to give two tips to the postgraduates. That one thing you have to understand that there are broadly two here. One is classification of VKH that you must read carefully, because that classifies into complete VKH, incomplete VKH, probable leakage, and this is how it is classified, and stages already you have mentioned. So this is very important. I won't go into the pathogenesis and all, but you have to understand two important points. This is a disease described by three separate scientists: Vogt, Kwanagi, Harada. Alfred Vogt from Sweden, and the other two from the Japan. And if you go by the history, you will realize that it took them 50 years to understand that all these three described by them are part of a single disease. So even now we see in medical colleges, people will see, and even in clinical practice, we see they will write that it looks like a Harada disease. If you read the classification by of VKH article, which has been a standard, the entire body has been formed and they devise that classification. There is a line that says that the terminology like Harada's disease should be prevented. One should not use the terminology like Harada's disease. It should be complete, incomplete, and probable. So this is very important for the postgraduates. The youngster will be coming to the clinical practice to understand that what kind of nomenclature we are using. Coming to two quick points here, I would like to give. One is that you have to understand the VKH. Anyway, the most important part of the management of the VKH is to prevent the recurrence. The entire management depends on how you can prevent the recurrence of the disease in future. I think that much from me. Samayek, you can add little more.
Yes, sir. I think Dr. Partho is like he was like rightly introduced. He's an encyclopedia, and he goes back to the history of VKH, and I think he's put it really nicely. Anuja, you had a very nice presentation. A couple of things I would like to add. So, clinical picture was very much suggestive of VKH. So, it's essentially a clinical diagnosis. You can add a few ancillary investigations to make your point that this is indeed VKH and nothing else. For example, you can do a ultrasound looking at the peripapillary retinochoroidal thickening if there is actually a retinochoroidal thickening, which is a non-invasive modality and which will help you well to actually diagnose. You can also do a audiogram to actually chart out the kind of hearing loss, sensory neural hearing loss that is seen in the early stages of VKH. The other thing is, if you could get an angiography done, then it would help you seal the diagnosis. All right. So you are confirming the diagnosis like you had suspected initially.
Yes.
And because it is very much indicative. The other thing is, in the chronic stages of VKH is where you will find the integumentary findings. Like you perfectly said, that it's in these stages that you find the integumentary changes, because the pigment loss starts happening from those areas as well. And that's where you find hypopigmentation, poliosis. So it's a spectrum. It's not only limited to the eyes, but it has underlying manifestations as well. And that's where in the acute stage you have to treat it really well. You give IV methylprednisolones for 3 to 5 days, and then followed by oral steroids. When the disease recurs in the chronic stages, for example, you have treated a patient in the acute stage, patient gets better, goes back and gets lost to follow up and comes back again. So what you see in those stages is the sunset glow of fondness, because in the acute stage the pigment has already been lost, and further recurrences in the stage. So one modality what will help you here is the enhanced depth imaging of the choroidal thickness. That sometimes even without
Samayek sir,
of
audio is not
the
clear.
rate. So choroidal thickness will go up in such cases. So it's one point where you can actually monitor your response to treatment.
So, very well said, sir. So, ancillary tests supporting the diagnosis and ophthalmic investigations like ultrasound, OCT, OCTA, and FFA ICG. Very well. So, moving ahead, we've diagnose the condition. Now moving ahead with the treatment. So in the acute stage and in the recurrent stage with complications, what are the different management options available? I think we can start with this discussion. I think Samyak sir would like to start.
So, like it was said, in the acute stage, you want to really take down the inflammation, in a very strong way. So, intravenous methylprednisolone, 500 milligrams to 1 gram per day for the next 3 days to 5 days. You can even extend it to 5 days, followed by oral steroids, 1 milligrams per kg per day, and very, very slow tapering. So, you should not taper them fast, not in 10 milligrams, but if it is possible, you can taper it at 5 milligrams every 2 week levels. So it's that kind of a disease that even if the clinically you see the subretinal pockets resolving and the vision getting better, it is a you have to understand it's a choroidal disease. So you see choroidal granulomas there. So that will take some time to settle down. If you are very sure that this is indeed VKH disease, if you have confirmed it by the ancillary investigations, then you can start on immunomodulatory therapy as well, simultaneously once your disease diagnosis is clear. And there you can use azathioprine or mycophenolate depending on the choice of the immunomodulatory agent. In chronic cases, when you have these recurrences, and if you have really, really difficult cases that they are not getting uh, controlled even by immunomodulatory treatment, you can step it up to biologics. And I think Dr. Partho will elaborate that he's used adalimumab in cases of really recalcitrant cases of VKH. But those are the select cases. Yes, Partho sir?
Yeah, for because it's a PG program, I won't go into the biologic and all. I just I would highlight that the postgraduate must understand that why we are not using biologic or azathioprine as a first line treatment in case of acute leakage. So here the purpose is to use a supra pharmacological dose of oral steroid, which is the bolus dose of steroid, to reduce a severe inflammation in the choroid. And as Samay told, it is the stromal choroiditis. So it has to be treated very aggressively. So what we do, for example, if a patient has developed VKH and sensory retinal detachment, and if you give azathioprine treatment to that patient, so how long it will take to take this azathioprine drug to reach the desired level of concentration? It will take 3 weeks time. 2 weeks to 3 weeks time. After that, the drug will start working. So even though we feel that the immunosuppressive or biological, these are very sophisticated treatment, you have to understand their onset of action is prolonged. So you can't use them. On the other hand, if you use this suprapharmacological dose of steroid like IV methylprednisolone, it can reach the uh, retina, especially the detached retina, within 2 hours of time of administration. So this fundamental difference between these therapies, no, you must understand. And the second thing is that you have to then continue the treatment with a high dose of steroid, and you can't continue high dose steroid beyond a certain limit of time because the steroid will have their effect. So that's why we'll use the azathioprine. Mainly, we use azathioprine or any other immunosuppressive drug, which will continue for a longer interval so that it can prevent the recurrence also. So basically, that is the clinical principle of treating a case of VKH. You have to use a immunosuppressive so that you can continue that, because VKH is notoriously, it is recurrent inflammation, and each time if it is poorly treated, then it can cause severe recurrence. The recurrence intensity of the recurrence increases in severity. Another important point you have to understand, sometimes you will encounter cases which has been poorly resolved and not fully settled down. The most common cause is that poor treatment. Often what we do, a patient with 80 mg body weight, 80 kg body weight or 60 kg body weight, we start them on 40 mg to 30 mg steroid. So that is called the poor. You are using a underdose for a patient. So that should not be done. You have to use a proper 1 mg, and Sima clarified that 1.5 mg kg body weight you have to use it. And also for postgraduate, I want to highlight that there are two modalities of treatment for intravenous corticosteroid. One is methylprednisolone and another is dexamethasone. So we prefer methylprednisolone because it is intracellular penetration is much more than the dexamethasone. But in where there is a some financial constraint is there you can use the dexamethasone. That's it.
Okay. Thank you so much, sir. So now we'll move on to the next part of our webinar. I'll be presenting some case scenarios, two case scenarios, and we'll be sharing the expert opinions on those. So I'll just share my screen.
These are
So,
sir,
yes,
just
sir.
to have the your opinion on how to proceed at both practitioner level and for the PGs as well. Ashish, go ahead.
So the first case scenario is a 65-year-old male who underwent a cataract surgery 2 weeks back and came with diminished vision since 2 days, and the anterior segment was quite, there was good
Excuse me,
pseudophakia.
we are
Ashish,
not able to see your proper
PPT is not open.
case. Yeah.
It's not seen now. Is it seen?
And just see the home page.
Okay, I'll just share. Just a minute, sir. Now, is it seen?
Now we can see your Zoom platform. Now we
Now,
can
Okay.
yeah.
see the page. Yeah.
Right. So the first case is a 65-year-old male who underwent right eye cataract surgery 2 weeks back and came with complaints of diminished vision. And on examination, the anterior segment was white with a good pseudophakia. And the fundus examination revealed a dull foveal reflex. Rest everything was within normal limits. The OCT revealed a loss of foveal contour with cystoid spaces and central foveal thickness measuring around 560 micron. The vision was good on post-op day 1 and deteriorated at 2 weeks, and this was the OCT finding. So I would like to ask the panels on the various options available with us and what would be their choice of treatment. Uh,
Partho sir?
Partho sir or Samyak sir?
Yeah. Samek, you want to take that?
Yes. So
You
this is a
can
case of
respond to your PPT or stop sharing. We are seeing
Yes,
your.
sir. I'll stop that. Yes, sir.
yes. So for this uh, immediate appearance of post-operative cystoid macular edema, I would give it a, I would look at the fundus. I would go back and ask if the patient is a diabetic or not, because sometimes patients are borderline diabetics and they say, no, I'm not a diabetic. Sometimes they say that I have no sugars, but they are taking medicines which their sugars are controlled. So we go back and look at the fundus if really is there any diabetic macular edema or any evidence of any other, for example, a branch retinal vein occlusion. Sometimes a macular BRVO in the past, which has been missed due to the cataract, can come back and present as macular edema. So that's one of the most common. So go back and look at the clinical picture. And if you have to do something, if there is none, no macular edema due to diabetes or due to a vein occlusion, I would start with just probably topical non-steroidal anti-inflammatory drugs.
Okay. Partho sir, would you like to add something, sir?
Yeah, the patient is 65-year-old with this kind of macula. No, I won't take chance. I'll straight away go with the, if the patient can afford, I'll go with the Ozurdex. If it is not there, then because Samayek has made my job easier by telling all these findings and all. So now, with this kind of clinical picture, I'll just go directly with Ozurdex because I can't allow the patient to be in such conditions for a longer time. And or I'll give a tricot injection.
So tricot in the subtenon space or intravitreal, sir? Subtenons. Okay. So, Samit sir, how long would you wait for the NSAID to see the action, sir, through?
I think NSAID would start acting within 3 to 4 weeks. So I would give it 3 to 4 weeks. And I think the, in my belief, the best action of NSAID, in fact, Nepafinac is for cystoid macular edema, which is post-operative. So I would give it 3 to 4 weeks unless the vision is deteriorating or the macular edema is increasing in the next 3 to 4 weeks. I would still stick to NSAIDs and see.
Sir, both of you, any predisposing factors or any high risk factors that we've seen which predisposes to the pseudophakic CME that we see in the post-op, like you've known that this patient might develop, or any specific predisposing factors that you might like to mention?
Any intraoperative complications, any vitreous loss, or eventful cataract surgery, if you may put it like that.
Any vitreous loss, any traction, rightly said by Samyak sir. Okay, so any role of anti-VEGF or vitrectomy in this disease, sir? In resistant CMEs or in long-term edema that you've noted?
Partho, sir?
What? No, I would prefer that.
Okay. Okay. Samyak sir, anything to add on this?
No, I think if it is recalcitrant or not improving, I would agree. I do agree with Dr. Partho that we would go for Ozurdex, and I think that will take care of that macular edema. Anti-VEGFs would have a shorter period of action, and if it is not indicated, I wouldn't go for anti-VEGF. Ozurdex would be a better choice. And unless there is traction on the macula, if there is an epiretinal membrane which is causing the macular edema, then it would make sense to go ahead with the vitrectomy.
Sure. Okay. Thank you so much, sir. I'll move on to the second case. So, just summarizing it.
I want to highlight one point. Sometimes in some situation, no, I know I'm talking about a very rare possibilities, but sometimes that single piece lens, no, is placed in the sulcus. So sometimes it can cause CME. So I think that's the important point while just dealing with such cases. No, one should look carefully whether the lens is properly placed in the bag. Anyway, continue.
So inflammation due to iris rubbing due to the haptics of the IOL causing
sometimes it can come with only with macular edema. I have encountered.
Correct. So also in some cases we note vitreous stands in the AC, which after 2 to 3 months, would you like to do a vitreolysis, YAG vitreolysis, or go in and cut it? That will also help the CM to resolve.
Yeah.
Yes, sir. So okay, moving on to the second case now. So case 2 was a 45-year-old female who presented with a gradual painless diminution of vision in the right eye since 6 months. She had history of redness in the eye on and off since 2 years, for which topical medication was taken. The vision in the right eye was finger counting 1 meter, not improving. The anterior segment image was this. She had a festuled pupil with posterior synechia and a complicated cataract. The B scan was done, which revealed dot echoes that the retina was on. So moving from here, I would like to ask the panelists on how would you all proceed ahead with the investigation and the treatment part, sir. So, Partho sir, would you like to start?
The quiet eye, right? I missed that point. It's a quiet eye you said, right?
Yes, sir. It's a quiet eye right now. The AC was quiet.
My first step will be there to identify the cause of this inflammation, and if it is idiopathic, then number two, what I'll do, I'll ask the wait for at least 1 to 2 months after starting the steroid, because you can see here there is an extensive synechia. And the moment you will cause synechiolisis and cataract surgery, there will be severe inflammation in such eyes. So I'll prefer to give a course of steroid and topical NSAID also, and wait for some more time, and then we'll touch the eye.
Okay. Dr. Samyak sir, would you like to add something?
I agree with Dr. Partho. Only thing is I would add some cycloplegics to it. Probably atropine or hometropine, just to see.
Correct. Okay. And sir, also the role of PSTA Kinacort and intracameral triamcinolone during the cataract surgery. Would you like to combine these if it's a smaller duration of period to control the inflammation? Because
we missed it, I think.
It's a 45-year-old female, sir.
45-year-old female. No, I'll prefer not to give a tricord. No, sometimes this patient, they develop a drooping of eyelid after giving a tricord, and that causes another problem. The patients are very unhappy after the surgery. So I won't use that.
And intracameral triamcinolone, sir, during the surgery, at the end of the surgery, would you like to do that, or do you prefer?
I don't use. I don't know about others, but I don't use that.
Samyak sir? Sir, voice is breaking again, sir. Yes, sir.
So what I give perioperative, maybe a short course of oral steroid, you are going to break the sinus. So it's not going to be this routine cataract surgery. It's going to be slightly difficult for the surgeon, and it is going to be slightly difficult for the patient as well. Sometimes the pupil may not dilate. You may put a pupillary expander. So there is going to be a lot of manipulation of the iris tissue. So in such case, if you start a preoperative oral steroids, probably 2-3 days ahead of surgery, and then taper over a period of time, continue cycloplegics after the surgery for some time, it would help. So that I think will make it slightly better than just intracameral steroids. That's what I feel.
Also, sir, which is the choice of mydriatic that you use in the post-op period? Because in many cases I've seen they form the synecdoche at the dilated pupillary margin with the IOL or with the capsule margin. So, what would be your choice of mydriatic or cycloplegic at the post-op period, sir?
Might twice a day.
Twice a day. Okay. Okay. And sir, if in this case, if the vitreous had shown more echoes, would you still go ahead only with the cataract surgery and then evaluate the posterior segment, or a combined surgery is ever preferred by you, sir?
Sorry, if the vitreous is
If the vitreous had more echoes, a significant haze, if it was seen even with 1 month of steroid, if it's just vitreous degeneration or maybe haze, would you still go for a combined surgery, or it just be a cataract, evaluate, and then
we'll go with the cataract surgery only, and after that we'll examine the fundus, and based on that we'll take the next course of action.
Correct. Okay. Thank you, sir. Thank you, Samyak, sir. Thank you, all the panelists. Thank you, Anuja and Vinaya. Sumit, sir.
Yeah. So that was very well conducted, Ashish. Thank you. Dr. Varshav sir is here, Avinash sir is here, Samyak sir, and Basu sir. I would like to ask one by one, are there any suggestions that we can make it more better, anything in this program, just for the benefits of the PG? We are doing wet labs and otherwise everything district wise, but on the online platform, any suggestions from you, Partho sir?
I think this is a very interesting, wonderful initiative by MOS. I really like the idea. Maybe you can take the feedback from the postgraduate how they want it, like what kind of discussion they want to have, whether it is little theoretical, because nowadays you have means a lot of information available online and all, but they exactly what they need, that is important for us to know, because whenever we come and talk or give a presentation, we give it from a clinician's perspective, so that postgraduate teaching is sometimes missing. So I think they will be the best person to give us that what exactly they want.
So, Mike, sir?
I agree with Dr. Partho. The only thing I would like to add on is we should let some of the PGs ask questions. So it's very important to know what they feel about that specific case. For example, Venya and Anuja must have seen these patients of Eales disease and VKH. So we want them to actually ask that, has their queries been solved? Did they find anything difficult in evaluating the case, or did they find something different from the textbook pattern? So I think that would make a bit more interactive.
Okay, sir. Varshav sir?
Yeah, I think you should keep it little more simple and basic, wherein they can get a take-home message. So, yeah, rather than taking a difficult cases, exam-oriented or a little basic, so they should have a more take-home message.
Okay. Dr. Avinash Ingoye, sir, also I can see. Sir, are you available? Avinash,
yeah, I'm available. Can you hear me?
Yeah, very well, sir. Thank you.
One minute, just a minute. Actually, I agree with Dr. Samyak. The thing is, it's better that the presenter also asks some doubts to the experts. So by that way, it will be both ways, Otherwise, what happens is the PG is presenting a case, he's facing the questions, but there are certain doubts which they can clear, especially they have seen the case or they have taken the case presentation. Otherwise, Sumit, I really congratulate you for such activities, and it's been very wonderful, especially for postgraduate students, because they can learn and how to face the certain questions in relation to the that particular case. Thank you.
Now,
Thank
PGs
you.
also can put their views. PGs, do you want to add something?
Vinaya, Anuja.
So this has been a very good opportunity in terms of learning as well as presenting, and it was a very good experience sitting amongst the professionals and actually hearing the practical part of it as well, rather than just theory which we have already studied coming before coming here. So this was a very good experience. Thank you, everybody. Thank you so much.
Thank you, sir. Actually, this gives a lot of good exposure. I agree with Venya. Like, we are always very much scared to speak up because we hardly know these things. We are new to it. So, I feel this is a very good exposure, and in front of such eminent personalities, we are getting the opportunity. And coming to the diagnosis part is something that we always struggle with. Some maybe it is very simple for after gaining experience, but for new people like us, sir, while presenting the case, we really go through the theory in such a way that we also realize how to diagnose the case better. So this was a really good opportunity, sir.
Good. Thank you.
Vardhaman, sir.
Yeah, I think this was wonderful session, Sumit, and wonderfully moderated by Ashish. Wonderful discussion, a lot of pearls. I think one thing that I see is, of course, as both Partho and Dr. Samyak has told already, of course, this is should be, of course, as much possible PG oriented. But one beautiful thing that we see here is that the some of the pearls that the postgraduates learn here probably cannot be learned through textbook also. So I think they also learn a lot of good practical points. And we also see a lot of general ophthalmologists and comprehensive ophthalmologists are also actually attending these sessions. So they are also learning a lot. But of course, as everybody has suggested, the aim is to make it as beneficial for the postgraduates. And that has been also the core, let's say, interest also for Sumit. So he has been talking to all the postgraduates for all these months and making it better each time. So definitely, I think thank you to everyone for all the feedback. And of course, it was a wonderful pulse shared by both Dr. Partho, Dr. Samyak, a great mentoring by both Dr. Gore and Dr. Hiteshi, amazing moderation by also Dr. Ashish, and wonderful coordination throughout the year by Dr. Sumit. So I think it was a overall a great pearl-filled webinar, and I think all our postgraduates, compared to I think when we were postgraduates, we see that they're really very confident and they can really speak well. They present with great finesse. So both Dr. Anuja and Dr. Vanya have done a great job, absolutely. So definitely, and of course,
We also give means
bye.
congratulations. We should extend our congratulations to their teacher also,
Yes,
because
and
they
the
have,
teachers, very
they have
true. I
prepared
think
it very well.
the teachers are really making sure that you're well prepared.
Yeah.
And of course, I think I would like to also have a small comment from both Dr. Aditi and Dr. Santosh Agarwal, sir, before we call it off. Yeah.
Yeah, it was a really
Uh,
learning experience. The Dr. Partho and Dr. Samyak has given a very good means pearls of wisdom in all the cases. In our practice also, we face so many problems. Decision making is very difficult many times, but they have given the insight how to diagnose, how to treat the patients in various situations. And also, I think PGs also learn few advanced things also. They will also learn how to go about what should be the approach in every case. And many times, examiner is also interested to ask some advanced cases, advanced question also, questions on advances. So better it is a learning experience for both for PGs as well as for the practitioners. So I think overall the webinars are giving good insight of the topic, and they are making the experts are making the topic very means easy for all of us. Thank you very much for sparing your valuable time for us, and I'm really thankful to Vardhaman and Sumit and Aditi for regularly organizing these webinars and taking our MOS flag on a very high platform. Thank you very much.
Thank you, all the panelists and participants. Thank you, sir.
Thank you, everyone. Thank you for the opportunity, sir.
Aditi, you
Thank
want
you
to
so
say
much.
something?
Yes,
Concluding
I
remarks?
just wanted to add one thing. I always feel that, I always feel that when we are preparing PGs for exams, that is just a short-term goal for us. So they should be surely prepared for the exams, but they should be more prepared for the actual clinical experience which they are going to face case-to-case basis once they finish their PG. So I think these webinars are like kind of a very good combination. It is surely making them ready for the exams, but it is adding few points which are going to be really important for them in their day-to-day practice once they finish the PG. So I think this is a good combination which is serving both short-term as well as the long-term goals, because that is going to make the PG complete by getting prepared for the exams, but also for actual clinical cases. So yeah, I would agree that it's a very good opportunity for PGs. I would have loved to have these kind of webinars when we were also PGs.
Yeah, definitely.
Absolutely, we got like good exposure being in good institutes, but still, this is something
but I
much
think
better which
one
is
thing
available. Yeah.
these webinars are doing is that it is actually creating a common ground, and these postgraduates from every institute from nook
Yes.
and corner are getting similar benefit and teaching.
Exposure. Yes, yes. I totally
Fortunately,
agree to this.
yes. So I think that is because now I think if they have to go to and learn
Most
from Dr.
important is
Partho,
our Dr. Partho and Samyak like people. We are getting, they are sparing their time, and
yeah,
we are getting their insights about the topic. That's
absolutely.
very good, I think,
So,
for PGs also.
so that is the beauty of the virtual medium.
Yeah.
Fortunately, that we can have Dr. Partho to teach our students in Maharashtra, and Dr. Samyak sitting in Mumbai can impart his knowledge, because otherwise if they have to go all the way to Shankar Nitralaya, make so much of
Yeah,
effort. So I think it's a great boon for all of them. Yeah.
Thank
Great.
you, everyone.
Yes. Thank you. Thank you, everyone, for sparing your time. Thank you, especially Sumit. Thank you so
Thank
much.
you, everyone.
Good night. Good
Thank you
night.
so much.
Good night. Good night.
Thank you.
Bye. Good night.
Thank you, everyone. Good night.
Good night. Thank you.